To see you again. As ma'am said, today we are going to learn about one of the important sessions, psychosocial issues in palliative care. Now we understand, we all understand that how much importance we can given to that psychosocial, psychological part, psychosocial issues in palliative care. That is very, very important. If they have a psychosocial issues there, definitely their physical distress will be increasing. That also we understand. Today we have Miss Mukta Dhavalikar with us. She is a registered clinical psychologist. She completed her MPhil in clinical psychology from Amrita Institute of Palliative Sciences, Kochi, Amrita Institute of Medical Science, Kochi. And now she is running her own clinic in Goa in the name of Manove. And also she is a consultant clinical psychologist at Dilasa Palliative Care Center at Goa. So she has 5 years of experience in palliative care. Welcome Mukta, and over to you.
Thank you so much. Let me just start my screen share.
Okay. So kindly switch on your video and listen to the session response.
Yeah, is it visible?
Yes.
Okay, yes. Okay, all right. So let's start. Again, a very big thank you to Pallium India for this wonderful opportunity to interact with another batch. And thank you to all of you for taking this training and stepping into this field, which is so very close to my heart. And I know that you all are nurses who are new to the palliative care setting, who are just getting introduced to it. But you might have had some idea about what palliative care is, some basics of what it is. So can someone tell me what you know about it? What according to you is palliative care? Anyone?
Please unmute yourself and talk.
You can, it is okay if you're wrong. It is not, there is no right or wrong answer to this. You can tell me what is your understanding. So it's not an exam. I'm not judging you.
Good evening, ma'am.
Yes.
Palliative care is a care which we give when patients have a chronic disease or a condition which can lead to death. It is comforting the patient or giving quality care to the patient.
Anamika, you can continue.
Yeah.
I think I have given the definition.
Oh, okay.
Yeah. So you said that it is about comforting the patient. Absolutely. Anybody else?
So
I think in the chat also we have a few responses.
Yes.
Providing quality care during end stage, okay. Improving quality of life while they live with a chronic illness. It needs a multidisciplinary team to provide holistic care. Absolutely, yes. So a lot of you have told about a lot of things, that it's holistic, it's about improving the quality of life. It is about providing comfort to the patient, definitely. So if we had to go and look at the definition of what is palliative care, what WHO says is that palliative care is treatment aimed at improving quality of life of patients and their families who are facing problems associated with life-threatening illnesses. It prevents, it relieves suffering through early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. Okay, so what strikes us from all of this is that they say quality of life of patients and their families. And it also says problems including physical, psychosocial, and spiritual. Right? So let's move away from this definition a little bit. And instead of just theoretically understanding, let's look at practically what we go through every day as we go to work. When you go to your workplace, your hospital, ward, OPD, wherever that you're working, and you look around the waiting room or the ward, what is it that you see? When you look at the patients and the families, what do you notice first about the person who's suffering? Can someone tell me? What is it that you notice about your patients when you see them? Do they look happy to you? Are the patients happy? No, you see that patients are unhappy, right? They're in stress, yes. They're anxious, yes, absolutely. Right. So we see that patients are unhappy. They look emotionally distressed. Some of them are crying. Some of them look scared. Some are restless. They're pacing up and down the ward. So now imagine that these patients are suffering from an illness which is either degenerative or terminal or is causing them severe pain. What is going to happen to this person, right? So we realize that the patient is not only in physical pain, we see that they're also in emotional pain and distress. There is also a component of psychological, social, and spiritual distress that comes along with the physical pain that they have. Right? And the quality of life is also really hampered. They're not able to do things which they once did so efficiently, things which added value to their life, like they earned for themselves, they earned for their loved ones, feeling good, mind and body, being able to do things that they love, going out, playing, spending time with friends, enjoying eating good food. So all those things, so much which added quality to their life is now lost or it is reduced. So palliative care is all about looking into all these aspects along with pain and symptom management, right? So we talk about holistic, whole person care. We talk about psychological well-being, spiritual well-being, emotional well-being, and social well-being. And apart from the fact that illness affects well-being in all these areas, we should also not forget that there is a mind-body connection, which is a two-way connection. Right? So just the way body affects the mind also affects the body. And we have seen, our studies also show that emotional distress often will exacerbate people's pain perception. And it can also affect, it can impact the physical well-being and at times even the disease trajectory. And again, the caring is not limited to the patient only, right? It goes beyond that. We are also caring for the caregiver as well, the patient, their family, their children, all these people. So why is that? Why is family the unit of care here? What do you think? Why are we looking after the families and not just the patient? What is your understanding of why are we considering family as the unit of care in palliative care? Again, you can give wrong answers. There is no, you can make mistakes. It's okay. So you can unmute and tell, or you can put your answers in the chat. Okay. Because they're in trauma. Okay. Anything else? They need psychological support. Absolutely. Financial issues. Okay. Yes, absolutely. All these reasons are right. First of all, why we considering the entire family is the patient's symptoms and how the family is coping with the illness is not really unrelated to each other. We need to address both of these because it's healthier for both. Let's say, for example, if there is a 37-year-old woman who has a life-threatening diagnosis, is it traumatic for her that she has got a diagnosis which is life-threatening at 37 years of age? Yes, very much traumatic. Now, is it also equally traumatic for her 40-year-old husband that his wife has such a diagnosis? Would it be traumatic? Or for her 10-year-old child or her aging mother? Right? The emotional and physical resources, right from the money and savings to their emotional resources like resilience and their ability to deal with stress. All these resources of the entire family are going to be threatened with this kind of a situation. And so it is a family crisis. It's not an individual crisis here. The patient is not isolated. They're a part of a family system. And that patient's psychosocial physical health is going to impact the family's health and vice versa. So you might also have seen patients with terminal illnesses who had partners or spouses who suffered from depression or some other psychosomatic symptoms, and their health also deteriorated because they were not taking care of themselves, looking after the patient. The losses which are suffered by the patient are also losses which are suffered by the family. For example, patient's loss of role as the head of the family is also the family's loss of a primary breadwinner. Right? And in addition, of course, there is a lot of exhaustion, there is stress which comes with the caregiver duties, which can lead to burnout, which can lead to guilt at times even. And our role is to help them vent all of this out and to give them some relief from it. Also, due to inadequate understanding about what palliative care is, people don't know what palliative care is. And because of this, even a referral to a palliative care service is at times experienced as a crisis by the entire family. So family-centered care, where the healthcare team, the patients and their families have an equal partnership, is the basis of the work that we do in this setup. Right? Coming to you people now, you might agree with me on this, that it's not only a physical illness, that there are other psychosocial issues associated with it, that it is the entire family which is facing these issues. But some of you might have a question about why you need to know about it. You're not psychologists or social workers or psychiatrists, so what will you do in this situation? You need to know about this so that you can do the needful. As someone already mentioned in the chat, it's a multidisciplinary team. We all need to be aware, all the members in this team need to know all the possible issues that can arise so that we can identify, we can assess, we can do our bit to support them, and if needed, we can refer to a specialist. So there is a psychosocial dimension to the work of all the professionals who are involved in palliative care. And understanding this will definitely strengthen the practice of any professional who is working in this field. And along with this, considering that you're nurses, you have a very unique role, a very special role to play in psychosocial support, because you are the ones that the patient and family are most in contact with on a daily basis, often on a long-term basis. So being a constant companion, you are in a position to build a trusting relation with them very naturally. So you are the ones that they'll talk to, tell their concerns to, tell their stories to. So even if you can't actively do anything to help relieve their emotional suffering, you can always listen. Yes, and that is why we have all these in the training also. You will have sessions on communication skills on how to listen to these patients. And so never underestimate the therapeutic value of listening empathetically to the story that the patient is telling you, their life story that they are sharing with you. So you need not be able to hand over solutions to them, but just being able to give them a space where they feel heard, that is also going to be incredibly healing for them. Now, when I say healing, let's not confuse it with cure. Yes, that is something that I'd really like to clarify. We are not talking about a cure. Cure is about getting rid of the illness, which we know is not many a times possible in these scenarios. Healing, on the other hand, is accepting that change is occurring and stopping the struggle that they have with them and stopping the suffering which is coming with that change. Yes, so not looking at themselves as sufferers, but seeing themselves as people who have their own resources which can help them deal with this change. So looking inside and finding the strength to deal with all of this, that is what I mean by healing. And you can promote this healing in your patients and their families in a big way. So let's first look at what are these psychosocial spiritual issues which can arise in this context so that you'll be able to identify them in your patients. Along with that, let's also look at what can be done to assess the extent of distress and how to treat that. Now, it's not really possible to separate out these issues as psychological, social, and spiritual. We can't categorize it into neat categories because up to an extent, they are pretty much overlapping issues. So when we are discussing a particular issue, it will have psychological aspects, social aspects, and also spiritual aspects in varying degrees. So the first thing we are going to look at is communication. One of the first issues that comes up is communication issues and breaking the bad news. I won't go into the details of the communication part of it because it has been covered or will be covered in your course of training. But instead of getting into the protocol of how to break bad news and how to communicate, I'd rather draw your attention to what happens when there is not enough communication or miscommunication about the illness within the family. If we are doing this very hurriedly, if we as professionals are not communicating things properly to the client, to the patient when they come in, that this can cause further problems like arguing, non-compliance with treatment, especially if people have misconceptions about the diagnosis and the kind of treatment they are going to receive from us. So supporting and educating the family is very vital. It's important that they have an adequate understanding of the illness and the expected process. So we need to give enough time to address everyone's concerns about it and to help them communicate clearly if they have any doubts. Speaking of communication issues within the family, even the most functional families find it very difficult to talk openly about this. So they naturally tend to hide their feelings and to not tell certain things. And they do it to protect family members from feeling hurt. So they might either hide their distress from each other, or they'll hide the news in the first place from the patient, or especially if there are small children involved, they'll hide it from the children. So that is what happens when I say miscommunication or not communicating enough. Before I began practicing, when I was under training, a lot of my work was with pediatric cancer patients. And I don't remember seeing even a single parent who didn't hide their own pain and sadness and fear from their child. Now, why did they do it? Because they felt like they needed to stay strong for their child. But the problem here was, even if they didn't communicate with words, their body language, the way their expressions were visible to the child. So children could sense that there was some hidden restlessness, some anxiety, that their parents were hiding something from them. That was even more unsettling and scary for the child. So usually there is no choice about whether or not to tell them, especially when it comes to children. Because one, they'll read emotions around them. They'll notice adults talking in hushed voices, quickly wiping tears. They'll respond to body language. They'll see sympathy in people's eyes, and they'll be aware of changes in their routines. So honest and open communication in a way that the person will understand, or if they're children, in a language that the children will understand, is the key in this case. And we need to help patients and their families see that if they are misguided in their attempts to protect their family from harm. So one of our major roles is in facilitating open communication and expression between members of the team and between families and treating teams also. The second issue that we come across, the first is communication. The second issue is predominantly social in nature, and that is loss. When I say loss, there is definitely more to loss than just the loss of life. So many different kinds of losses are experienced by patients in relation to their social world, with the way they engage with that world outside home and with the roles and relationships in the family. So there is a loss of future. There is a loss of identity, of role, loss of social engagements, loss of self-esteem even associated with that identity. For example, let's say I'm a teacher and I lose that role as a teacher because of my illness. That is going to be associated with so many other things, like loss of my financial independence, loss of my meaningful contribution to society, loss of living according to my values, of my confidence in my abilities to teach. So many things. So much of our self-concept is linked to who we are and what we do in a social context. So without that context, without having any social engagement, we might not even know who we are. And as mobility and energies will decline, it will become harder for the patients to participate in social events and to maintain friendships which were built on shared activities and shared interests. So social isolation is going to be a frequent source of social pain for both the patient and the carer. And now, in some cases, it is possible to an extent to get these patients to meet friends, to meet colleagues, to have meaningful interactions with them. But for some of them, you might have had these kinds of patients, met these kinds of patients who refuse to meet earlier friends and colleagues, etc. Because the thing is, there is a change in the way they feel about themselves and their declining function. There is a lot of gap between who they were before the illness and who they are now with the illness. So their past social engagements and their present limitations and conditions, there is a huge gap. So for these patients, one of the solutions may be to participate in new social groups altogether, instead of trying to integrate them into old groups. When I say new groups, what do I mean? For example, we have a lot of cancer support groups, or we have caregiver support groups, where they can both learn how others deal with these changed identities. They can compare their own situation, and they can continue to feel like they are making a valuable, meaningful contribution. So especially with patients who say that they have stopped talking to people because they hate the look of sympathy or pity in their eyes, that they see that people are hesitating in sharing good news, that they're talking only about the illness or treatment, nothing other than that. So such kinds of experiences could lead to a feeling of being left out or being unable to connect with those who are not affected by this illness and who are going around with their previous routine. And this can lead the person to withdraw further and cause themselves even more hurt and pain. Along with the patient, caregivers are also going to go through this. So they will also have a changed identity. They may be struggling to sustain other commitments, commitment to a job or to some other needy family member. They might have put life on hold because they put the needs of the dying person first, right? And that also causes them a lot of pain because their social needs are not met. And man is a social animal. You might have witnessed caregivers who help each other out in hospitals, who strike up a friendship in the ward. They'll help each other out, talk to each other, share food. So, and they'll do all of this naturally because of their need to connect socially. Because they feel understood. They feel a sense of connection with people who are going through something similar. And that is why support groups can really help when it comes to loss of social identity and loss of social engagement, when it comes mainly to social pain. Right, moving on, we come to the next topic, or the next psychosocial issue, that is unfinished business. What do you think this is? What do you think is, what does this word tell us? What is unfinished business? Is everyone awake?
Please unmute yourself and talk, or put your answers in the chat box.
What do you think this could be? Just put up a guess. What could be unfinished business? Family issues. Okay. Anything else? When we see the word unfinished business, we definitely know that, okay, unfinished, we understand that, right? When the patient still has hopes and dreams for the future, okay, yes. Goals, yes. Marriage of loved ones, okay. Thinking can't do anything, okay. Okay, so basically, as someone put in the chat, goals or hopes and dreams for the future, basically all those things that they have wanted to do, but is still left. It is still unfinished, right? All these things, unfinished business basically can lead to a considerable distress, and it can manifest in many different ways. It can come out as restlessness or anxiety, sadness, guilt, discomfort, helplessness, a lot of different emotions about the tasks which are left unfinished. So it could be about someone's dreams and ambitions, plans for life. For example, as some of you have put in the chats, also some examples, like marriage of some loved one, building their own house, taking care of financial commitments, maybe repaying loans, things like that. Yes, responsibilities which are pending, absolutely. So how do we identify these unfinished businesses? How do we know that the distress is coming because of some unfinished business of theirs? It's very simple. You just have to keep your ears open and notice. If you hear for patients' regrets, you would most likely get to know about their unfinished business. For example, if I had a patient who told me, I wish I had not stopped talking to my sister, because now when I look back, it seems like such a small issue, such a trivial matter, when faced with the possibility that I'll never be able to talk to her again. What does this tell you? That reconciliation, maybe asking for forgiveness, is an unfinished business. And if the patient would be able to complete that, then it would bring some peace to this patient, right? Mostly unfinished business would be a major concern in younger patients who are in their prime, who have children who are still small, still studying, not settled on their own, or who have parents who are aging. So here the unfinished business would be revolving around their responsibilities as a parent towards their children and as grown-up children towards their parents. And in this context, the most common emotional distress would come from the feelings of guilt of not being able to be there for them, and anxieties about how the children or their parents are going to cope on their own if they're not there. Now here, let me give you an example, or I'll tell you a story of a very strong patient whom we recently lost. And so I think this will help illustrate all the 3 points that we have discussed so far. Okay, it'll talk about, in the story you'll see how communication plays a part, you'll see how loss plays out, and you'll also see unfinished business. And it'll also help you see what I mean when I say that these factors are overlapping, that they're not independent of each other. Okay, so this patient, she was a lady in her 30s. Okay, so pretty young, and she was diagnosed with an illness only to know that it was in the terminal stage, that there was no curative treatment available at this point. And it was a very sudden and shocking news for her. She was faced with loss of identity as a young professional. She had to quit her job. And as days passed and she quickly deteriorated, and she was bedridden, became dependent on other people for her basic needs. She could not bathe herself. Even if she had to go to the toilet, she needed help to walk to that place. There was a loss of dignity, which was especially painful for her to bear at such a young age, because no one is prepared mentally for something like this when they're in their 30s. There was a loss of role. She had 2 young children, One of them was barely a toddler and she couldn't fulfill her role as a mother. That was definitely very hurtful. And her family was actually extremely supportive. They kept on reassuring her that they would take care of her children. So she didn't have any anxiety about who was going to look after them. But there was the pain of leaving them behind and not being there to see them growing up. It was something that she was leaving unfinished, right? And there wasn't much that could be done to help her complete the task per se, right? Because unlike other unfinished tasks, like what we saw in the previous example of reconciling with the sister, this was a very, seeing or helping her children grow up was something that was realistically not possible for us to help her complete. But what the patient did here was she asked her child to be brought to the hospital, her elder child. Yes, a girl, 12-year-old girl who was extremely attached to her. What she did was she asked for the child to be brought in and she sat with the child and she told her how ill she was. And she explained to her what a terminal illness means, what stage her illness was at. And she cried with her child and she told her that she loved her and that she'll always love her. As a palliative care professional, when she told me this, my first thought was that was such a beautiful, difficult, and brave thing to do. But that was not how her family felt about it. When she was telling her daughter this, her family had tried to stop her, constantly saying that she shouldn't be saying things like this, questioning why was she putting the child through this so much hurt and pain, etc., etc. And that really disturbed her. And she came to me with the question of whether she was being a bad parent by doing this. But somewhere she also knew the answer herself. She told me, I know they didn't want me to say it, but it's the truth. I very strongly needed to say it. And the reason why she decided to tell was, one, she didn't want it to come as a shock for her child because it was inevitable. It was going to happen. And secondly, she said, and these are her words, if I hadn't told then, I don't know if I would have gotten the chance to tell her that I loved her and that I wasn't abandoning her. Here comes the issue of communication. The family was trying to protect the child. They didn't want her to know that her mother was going to go. But as research with children of deceased parents shows us, it is best for the child to be involved in and given a choice to say goodbye. The ideal steps for us to follow here would have been to find out from the child what she already knew, because she would have definitely picked up on cues from the atmosphere, to help her mother communicate with her, if necessary, reassuring the mother that this was good parenting, to give her child knowledge of what was happening, and helping her identify sources of support for the child. And this lady, this patient, intuitively did all of that. Her only request to us had been to help her child through the process of understanding the loss and supporting the child through it. And in doing what she did, telling the child and making the request was, she did indeed take care of her unfinished business to the best of her ability in the given circumstances with the limitations of her illness. And when we validated her decision to communicate with her child, and when we assured that we would talk to her and that we would be there for her, she could give us a genuine smile. And that was the last we saw of her. Many a times, families are not ready to have this conversation. They would rather protect the child. But what they don't realize is by keeping them ignorant, we are doing just the opposite of protecting them. We are not opening up doors for them to ask their doubts, to prepare themselves for what is to come, and to ensure that they don't blame themselves, which children often do. So moving on, so far we saw communication, we saw loss, we saw unfinished business, and we saw that how all of these are really interlinked. Next comes a very practical issue, and that's financial problems. As we look into a comprehensive psychosocial assessment, we also inquire about financial concerns. Many times as people undergo long treatments over years without any money coming in, it drains out much of their savings. Some might be from a poor financial background to begin with. So financial issues is a very real concern. Why are we addressing it under psychosocial issues? Because it is a source of distress for many. It can even stop them from help seeking. There might be fear and anxiety about it, which again means that they might not respond very well to our treatment if these underlying causes of anxiety are left unaddressed. We need to talk about it. For some who have been well off until then, receiving charity or asking for help can also seem extremely difficult, because then they feel like there's a loss of self-esteem along with it. So what is our role in all of this? One is to talk it out with them. Listen to their perceptions, how they feel about taking financial help. Is there something that stops them? And secondly, to get them in touch with agencies that can provide aid. For example, at Tilasa, the place where I consult, we have an aid which is given by the Cancer Society. So the decision makers are informed about this right at admission. Again, right? For example, we had this patient who kept insisting immediately after admission that he be taken home. And he was very adamant about it. He had a young son who was working, just fresh out of college, but he had a job. And the nurses inquired with him whether he was not happy with the care that he received. Was his pain not being managed the way that he had expected? Basically, the nurses tried to find out what was the reason he so desperately wanted to leave. Then they realized that he was troubled, thinking that this is a private hospital and it's going to cost a bomb and we can't afford it. And being a proud man, he felt ashamed to share this with the treating team. But he told his wife, and she told her son. Now, what the son did was, he just kept on reassuring the father that you don't think about it, I'll manage it. You don't think about it, I'll take care of it. Which the patient felt was just a false reassurance. He needed to be involved in the process of financial decision making. Once he was told about the aid and how it worked, he was much more relaxed. And he also agreed to stay and continue with the treatment. So ensure that you involve the patient as much as possible in the decision-making process, not just in terms of finances, but otherwise as well, because that mainly it maintains the sense of autonomy and control in their lives. Next, we speak of spiritual issues. Yeah. Spiritual well-being is one of the most important influences on quality of life at the end of life. And patients might experience a number of spiritual issues, including but not limited to lack of meaning, feeling a loss of dignity, feeling lonely, hopeless, having anger towards God, feeling abandoned by God, feeling out of control, grief. A lot of things go into spiritual suffering. And this is not only limited to religiosity or faith. It goes beyond that. Because as one nears end of life or faces the reality of being mortal so closely, they might begin to have existential questions of what's the meaning of life? What's the purpose of life? And along with that, they might also start to think about the past and question, what did I contribute? What did I give to the world? What did I make? I mean, was my life meaningful at all? What am I leaving behind? So it is important to help them reminisce, to look at their past trumps, what they achieved. It could be something very simple. It doesn't have to be something special. It could be something as simple as raising good children, even in difficult circumstances, or being a valued employee of the company that they worked in. Knowing what they did was valued is what is going to keep hopelessness at bay. So reminiscing past trumps, knowing that what they did was valued is extremely important. And this is a time when, if you review the past, it puts the present in context. It can be very affirming to the dying person. And this can be done in several ways. For some people, informal talk with family and friends may well give the opportunity to go over the past, the traumas and the tragedies, and to receive confirmation from them, from the family, that their contribution has been valued. But for others, a more formal sort of a life review may be helpful in settling their anxiety and uncertainty. These kinds of formal life review processes have been developed in many parts of the world. They're also available online, these sorts of structures or semi-structured interview sort of a format, which you could use. For example, I'll try to send you links of some of these formal life reviews if possible, so that you could sort of use it in your setups. Again, I'd like to give you, when I say informal life review and how it helps, again, I'd like to tell you about one of our patients, an old lady, and we had the caregiver, they had a paid caregiver, and her grandson had come in to visit her for a few days. And so he was going to stay with her for those three days. And this caregiver, what he did was, he sat and he reminisced with his grandmother. So he asked her about past incidences when she was young, when she was his age, how did she meet her husband, etc. So, and in all these 2-3 days, she didn't once complain of pain in the entirety of his stay. So, and as this example shows you, and as research also shows us, there is a definite improvement in life satisfaction and reduction in stress after following such reviews. Along with this life review process, what else can be done is, so these patients might have a wish to leave a legacy behind or to be involved in planning for the future of loved ones. Some might want to have concrete gifts that they leave behind. For example, a poem that they wrote, a painting, a sari, a recipe book, a dress. A parent with young children who is dying may wish to leave letters, an audio or a videotape for the child to keep and to refer to as they grow up. And you can help them make these sorts of memory books with messages, pictures, or keep other small souvenirs, something personal for all the things that they would miss. For example, their child's birthday, marriage, graduation, the day they'll go for their first job, things like that. Basically, any material which will concentrate on demonstrating the value of the child for that parent. Yes, and reminders of times they shared, definitely likely to be greatly treasured, right? Like if you could put yourselves in the place of the caregiver and just imagine that somebody you've lost, a loved one that you've lost, has kept something of theirs for you, which tells you how much they loved you, how much valued or invaluable would that be for you, how precious. So help your patients do this for their loved ones as well. Making a will is another way of ensuring that your wishes continue to carry weight after your death. Many a times patients might, especially in the Indian context, patients might be unwilling to do this, unwilling to make wills. But it is definitely our job to at least put it forth to them, to make them see the value of doing this. Apart from this, spirituality, very simply put, is being connected to something greater, right? Something greater than our own self, a higher power, not necessarily God, not necessarily limited to religion, but a higher power nonetheless. So assessing a patient's spiritual beliefs, assessing the importance of spirituality in their life, exploring whether they belong to a spiritual community is something we need to do. Don't assume. Always assess if spirituality is important for the person. Don't just assume that it is or it isn't based on your observations. Once you have asked them about it, ascertain how important and how helpful it is. Even a simple question is often sufficient. Just asking, is your faith or spirituality or religion helpful to you? Or how important would you say this is to you? And going a step further and asking whether there are ways in which we as the treating team can support you in your spiritual practice. As can we provide you with something which will help you or facilitate you in your spirituality? And these are simple things. These are not major things that you need to provide. For example, again, at the Lhasa, there was a patient who reported to us that he used to visit a local temple every day in the evening. That was a part of the social fabric of his life, because that's where he met his neighbors and he got to know about what was going on in the neighborhood. And when we inquired if he had noticed when he was brought in, that we had a small place of worship in the hospital right at the entrance. He said yes. And he was bedridden. So we asked him if being able to go see the idol in the evening, to sit there, pray there for some time, would it help him in any way? And he said yes. It was just a matter of arranging for a wheelchair to take him to the next room and a nurse to go with him. It had never occurred to him that he could ask for it and that the hospital staff would be willing to do something about it, because according to him, this was a hospital. They were here to take care of his physical health. He never imagined that his spirituality would have anything to do with the hospital staff, and that they would be willing to do something to help him in that practice. So interventions need not be complicated. They need not be about super brain science. Mostly they just need to be compassionate and human for them to work. How does this help? One, for those who believe in it, concepts like soul, liberation, reincarnation, transcendence can help these patients deal with dying and to make meaning out of it. It can reduce suffering and facilitate acceptance of the situation, most of it. It acts like a buffer against distress, particularly against hopelessness, helplessness, depression, death anxiety. Transcendence, which means a belief in a higher power beyond human existence, enables connectedness. It removes the isolation of suffering by putting it in a larger landscape, by talking about the ultimate meaning of life. And if you go to see, the religious traditions of the world, regardless of where you go, have their own interpretations of suffering, and they also have practices which enable people to transcend their pain and transcend their immediate situation and immediate selves through prayer, through meditation, through different rituals, and the fulfillment of the ultimate destiny or fulfillment of the human soul going beyond suffering. So these spiritual concepts often do help people, especially for those who believe in it. Even for the family, almost all cultures, if you go to see, have post-death rituals, right? These rituals following death is how the family makes sense of their loss, how they process their grief. These acts of remembrances is what is going to aid the person in processing their grief. But make sure that you're not letting your own beliefs interfere, so that you're not pushing the patient in any way to engage in certain spiritual practices, or you're stopping them from engaging. Our job is to respect the patient's spiritual orientation or a lack of a spiritual orientation. We'll encourage spiritual practice if a person is already engaging in it or wants to engage in it, but not to push those who do not do it. So ensure that patients are given the opportunity to express their spiritual beliefs and practices in our own setups. Next comes grief and bereavement. Grief is the emotional response which is associated with loss, right? It's an inevitable dimension of our humanity, helps us adapt to adjust to this change. And this is a process which can be approached with courage if proper support is available. Intervention is not always required in this case. For the majority of people, although bereavement is going to be painful, their personal resilience will ensure that they normally adapt to this change. So there's no justification for a routine intervention, because normal grief is not pathological. It is necessary to process. As the patient and family journey through palliative care, we'll see that the clinical phases of grief also progress from anticipatory grief through the immediate news of the death to the stages of acute grief, and for some, the complications of bereavement. First of all, we need to know what is normal grief so that we don't pathologize it, right? So what are the features of normal grief? Emotional waves of distress, unavoidable crying, preoccupation with the thoughts of the deceased, reduced concentration, other somatic symptoms like restlessness, numbness, weight loss, fatigue, behavioral symptoms like social withdrawal, seeking consolation from others. In this kind of a situation, we just need to be a supportive presence. Let them know that we are available to help if they ever feel the need for it. But sometimes active intervention is required when we see some abnormal patterns. Yeah. So when I say abnormal patterns, one of it is definitely anticipatory grief. Anticipatory grief precedes death, and it results from the expectation, the anticipation that death is going to come. And there are common difficulties which can emerge in anticipatory grief. If a family member is showing anticipatory grief, there might be impaired coping, where the family member might just deny the seriousness. They might just withdraw from the entire process of caretaking. They might not be involved. They might show anger. And our role is to encourage them to express their feelings openly, to help them recognize that saying goodbye is a process. It's not a one-time thing. It's an entire process with opportunities on the way to celebrate the life of the patient, to express gratitude, take care of unfinished business, to reminisce. So that is what we need to do when it comes to anticipatory grief. And when it comes to complicated grief represents a pathological outcome which involves psychological, social, or physical morbidity also. This is mainly prolonged grief with difficulty accepting the loss, meaninglessness even 6 months or more after the loss. And it is associated with poorer physical and mental health outcomes and even suicidality. And this is when active intervention is definitely required immediately. One form of complicated grief is inhibited or delayed grief, which is an avoidant form of complicated grief, where you see that the person is completely normal at the time of death, and the grief strikes much later when things are back to normal. Complicated grief is more likely in untimely deaths, sudden deaths, traumatic deaths, when there's a lack of support systems in place, or when previous vulnerabilities exist, and in case of dependent relationships. So these are the things that you need to look out for. We also have what we call disenfranchised grief, which is also again a part of a type of complicated grief, I'd say. Disenfranchised grief mainly represents the hidden sorrow of the marginalized people for whom there is less social permission to express dimensions of loss. For example, in case of extramarital relationships, or in certain parts of the world when there is a homosexual partner and it's hidden from the society, it's in the closet. That is when we see disenfranchised grief. That is basically the hidden sorrow. They're not able to express it because of social restrictions that are there. And finally, coming to psychological issues, we definitely know the common ones. We know anxiety, we know depression, we know body image issues, including loss of attractiveness, and along with it, sometimes issues of self-esteem, self-worth. But basically, we can put all of these under the umbrella term of distress. What is distress? An unpleasant emotional experience of a social or psychological nature that is tied to and interferes with the ability to effectively cope with illness and illness-related treatment. Here, basically making of psychiatric diagnosis and rapid identification of patients in need of help is difficult in the palliative care setting for many reasons. One problem is that psychiatric symptomatology may be mimicked by side effects of medications or even by the disease process itself. Right? And that is why it gets really difficult for us many times. And underdiagnosis, under-identification of psychiatric disorders is highly prevalent, mainly because it's not being recognized by professionals. So being able to identify and assess is very, very important for all of us. Here is a table for your use and reference, where it just shows the key components of diagnosing major depression, anxiety, and adjustment disorders. So 3 of the most common ones that we see in hospital settings. along with how to rule it out, and what are some of the major features or the time course that you need to take into consideration. This will definitely be available to you because the presentation is going to be shared with you, so you can always use this for your reference. And as I said, that there is a underdiagnosis, underidentification, which is highly prevalent. In a drive to address this in the context of cancer care, NCCN in UK, the National Comprehensive Cancer Network, has promoted development of brief rapid screening tools for distress, which can be administered by any professional, a non-specialist even. And this is the distress thermometer is one of these tools. We know that depression is one of the most, frequently unrecognized and untreated because we keep dismissing it as normal reactions, even in the face of severe affective disturbance. And the most common diagnostic difficulty that arises in palliative care settings is how to interpret the physical or the somatic symptoms that patients present in the context of a possible depression. And the challenge is to determine whether these symptoms are part of depression or are they a biological result of the advancing illness. So the focus needs to be on the non-somatic symptoms, especially the classifying ones. For example, inability to access past good memories is going to be there in clinical depression. Or if it is just normal grief, then you will see that the patient's self-image is not going to change. They will readily respond to comfort and care, and they will be able to enjoy pleasurable activities and will value authentic connection. These will be absent if it is depression and not grief. Okay. Occasional thoughts of suicide are also going to be quite common in these patients. But if there is a frequent, persistent presence of these thoughts, that would indicate presence of psychiatric complications. Many a times when assessing risk and intent, it is the need for control over death that we need to acknowledge. Again, nursing staff have an important role in identifying patients who may have psychiatric symptoms because you spend more time in direct patient contact. It enables you to observe behavior more closely. And the nature of intimate nursing tasks may give an opportunity for patients to express any psychological distress. So you might not be able to identify specific disorders, but you'll definitely be skillful in recognizing that there is significant psychological distress here and that the patient needs to be referred. Okay. How can the doctor or nurse working in a palliative care unit establish that a patient is depressed, that the patient requires treatment or further assessment? There are a lot of different preliminary screening tools which are available. There are things like the phase scale, the distress thermometer. There are other scales which clinicians use, like the caregiver burnout scale, BDI, that is Beck Depression Inventory, etc. So basically what they do is they gauge the emotional temperature of the patient. How are they feeling in all of this? Now, in case of palliative care, many times patients might be unwilling to or unable to discuss symptoms, and we might tend to turn to the caregivers for information. But research shows that asking caregivers is extremely unreliable when it comes to psychological issues, mainly because their ratings are closer to their own distress. Many a times it's colored with their experience and their perception of the illness rather than the patient's perception. Again, when it comes to screening tools and scales, we cannot just generally use all that are available because not all are valid in the palliative care setup. Research suggests that Edinburgh Depression Scale is quite useful. So is Beck Depression Inventory, and there is one called Zoom Self-Rating Depression Scale. So use scales, but use them with discretion. One of the simplest, easiest, and most effective way to screen patients is to just directly ask, are you depressed? Sounds unreal, but studies show that it's one of the most reliable predictors of actual clinical depression. And definitely it's helpful to assess at admission, but always keep an eye out for appearance of new symptoms, just like you would for any other physical symptoms. And report. All members of the healthcare team can observe and subjectively report distress that they feel is psychological in nature. It could be fear, it could be anger, it could be sadness, or something which is psychologically mediated, for example, pain or breathlessness. This may or may not meet the criteria of a discrete psychological disorder, but regardless of the etiology or the diagnostic label, it's ultimately about the patient's subjective distress and patient's subjective comfort. And that is what we're here for. We need to help them with. And our work is not only to identify problems and distress, but also to see and help the patients see their current support systems, which can help with the distress, and the internal personal resources and coping strategies. So helping them identify their strengths in the face of all of this. Here are just some final pointers about what your patients need. The psychosocial aspects of care of the dying person, whatever their diagnosis, will include the need for understanding of symptoms and the nature of disease and the process of dying, of acceptance, regardless of their mood, sociability, their appearance, self-esteem, being involved in decision making, having some autonomy, some sense of control, safety, feeling of security, a need for belonging, a wish to feel needed, to not feel like a burden, need for love, expressing of affection and of human contact, spirituality, both religious and non-religious, and a need for hope, for an improvement in any aspect of their life or of their living. Doesn't have to be hope in terms of stretching or lengthening life. Hope can be for anything in any aspect of their life. In the provision of psychosocial care for people at the end of life, each of these needs need to be identified and need to be addressed. And some final do's and don'ts. When you're dealing with your patients, definitely be honest, be trustworthy. Don't make false promises, give some false impressions about what this treatment is going to entail. Don't respect people's rights to make their own decisions. Set aside your own biases. Don't pressure people to tell you their stories. Don't judge them for their actions or their feelings. Make it clear to them that even if they refuse help now, they can still access help in the future. And when you're doing all of this, when you're talking to your patients, ensure that there is confidentiality unless issues mentioned affect the safety of the individual or others. Provide them with clear, true information, honest information. And when doing all of this, when you're talking to the patient, don't talk about yourself, your personal issues, or your troubles. Don't minimize their issues. Don't philosophize or moralize or preach or impose your own religious perspectives. All right. And as you see, most of these needs and most of these do's and don'ts are not about you being able to provide technical therapeutic expertise, but about being a non-judgmental, compassionate presence who is witness to their suffering, who is giving them space to express their distress, and who's accompanying them on their journey, trying to help add life to their days, not simply days to their life. Thank you. And of course, one last thing is, which I forgot to mention, take care of your own stress levels when you're doing Yes. So any questions, any doubts, any feedback? Please feel free.
Thank you, ma'am, for the wonderful session. Anybody have any doubts on this presentation? Please ask her. So I don't think there is no questions so far. I hope everybody is understand well. because you were connected with your own experience also. So as Mukta ma'am said, this is one of the major problem. We are spending most of the time with the patient, we nurses. So we are the persons for we are the best person for assessing psychosocial issues. At least we should know whether they have any psychosocial issues. So if they have a psychosocial issues there, we can connect. We can connect with the medical social workers. So that we all know that teamwork. We need a teamwork. If they have a lot of psychosocial issues there, definitely we need to explore the psychosocial issues. So that we need a medical social, like psychologist or a social worker. So they are the persons to learn how to elicit the psychosocial problems and how to manage those things. So try to include that person is that medical social workers or a psychologist in that team, so that we can discuss together and do something for the patients. That way we can able to improve the quality of life of the patient. Okay, can we move on to the case presentation, Mukta?
Yes, yeah, sure.
Yeah, okay. So we can move on to the case presentation. Today, Oyo Boy will be presenting a patient story. So welcome and over to you.
Hi, ma'am. Good afternoon. Ma'am, can I use my slides? This is an updated one, if possible. Can I share my screen?
Yes, just wait for a minute. You can share it now.
Thank you so much. Ma'am, can you see my screen?
Yes, yes, your screen is visible.
Thank you so much, ma'am. So a wonderful day to everyone. I am Oyuboy Casimiro, pediatric nurse from the Philippines. I'll be your case presenter for today's session. So to start with, I'd like to show to you a quick review of the patient details. A 9-year-old female diagnosed with severe aplastic anemia. Then later on, the patient present the following complaints: shortness of breath, fever with 39.2 to 42 degrees Celsius, which is unstable temperature, gum bleeding, distended abdomen, pain, which is abdominal pain, 7/10 using the Flax scale, and loss of appetite. Then before the complaints, patient had multiple history of hospitalization due to bleeding. So as you can see on the history of illness, 4 months prior to the admission, the patient was complained about bleeding and admitted to nearby provincial hospital in their province. Then on the 3rd month, the patient was admitted to the National Children's Hospital, where the patient was managed and cared by the nurse and provide management for bleeding. Then the 2nd month prior to the admission, the patient was again admitted to the hospital, the same hospital, which is the same cases, which is gum bleeding, and managed to the hospital until discharged with no symptoms of bleeding. So as of the moment, patient is taking care of the hospital since August 8, 2022 up to now, and treating the condition of bleeding. Then upon history taking, the graphic representation of genogram reveals that from grandparent to grandchild, only 3rd child had aplastic anemia and no known history in the family. So examination reveal. So at this point, the examination and evaluation has been done to this patient. So immunization is complete. Physical examination, height is 122 centimeters, weight is 29 kilograms, and the temperature or the vital sign is 39.2 degrees Celsius to 42 degrees Celsius. HR of 160 to 170 beats per minute, RR of 25 to 26 CPM, and BP of 130/80. So with the oxygen of this patient then, it is 99% with O2 support of face mask at the level of 6 liters per minute. On the general examination of this patient, acutely disturbed, which is significant, which is positive delirium using the CAPD revised or the corneal assessment of pediatric delirium test. The patient score is 27, which is a significant score to have a delirium and suggest to manage the delirium. Skin integrity or the skin status of this patient, she has left and right periorbital bruises, petechia, upper and lower extremities, and intermittent diaphoresis. CBS, positive peripheral pulse, HR is above the normal range. Respiratory is labored breathing, which is causing them for shortness of breath. Abdomen is distended with abdominal pain of 7/10 using the Plaque scale. CNS or the Glasgow Glaucoma scale is 9/15. Eye opening is 3/5. Best verbal response is 3/5. Best motor response is 3/5. So same as well with the Plaque scale, the pain of this patient is abdominal pain, which is the most significant symptoms of this patient. For the behavioral status of this patient, she's experiencing sadness, irritability, loss of interest, and for the nutrition, she's starting to decrease the appetite. So just a quick view, this is the tool that we use for the pediatric client to assess the delirium and the pain. And for the treatment and significant investigation, for the chest X-ray, it reveals that the lungs show low volume with vascular crowding by without definite focal capacity since August 10, 2022. And for the CBC test, series of tests was done and performed, and it's significant that the blood components are consistently low despite the treatments such as series of blood transfusion and the like are done. So with the case of this patient then, since she had aplastic anemia, the body stopped producing enough new blood cells to sustain the needs of the patient. As you can see on the day from the beginning that the patient was last admitted in the hospital from August 10 to September 13, it is significant that from the hemoglobin, hematocrit, WBC, RBC, and platelets are still low. Okay. Then eventually, upon assessment of the psychological aspect of this patient, so this patient is from the southern part of the Philippines, approximately 186 kilometers from the National Children's Hospital, which is the main city of the main capital of the country. Third child among the 4 children. The father is construction worker earning 40,000 pesos or equivalent to $245 per month. And their wife is a housekeeper. Loss of appetite due to progressing condition that leads to body weakness. Loss of interest, signs of irritability is noticeable. She had episode of irritability towards to her watcher. Refer the patient to palliative care for understanding of disease and prognosis and supportive management. Hospital bills are being assisted by the hospital social worker or our palliative care social worker. And for the medications and treatment done to this patient, series of antibiotic has been completed, but still the patient is prone to infection, meropenem, clarithromycin, amikacin, cefepime, and magnesium tablet was being given to this patient then. For the ongoing treatment of this patient to control the symptoms that we discussed a while ago, we have paracetamol 290 mg every 4 hours and as needed. Morphine 5 mg, PIB Q4 hours for the DOB. Then midazolam 8.7 mg, PIB PRN for delirium. Magic mouthwash gargle 3 times a day to control the bleeding. Tranexamic acid 500 mg, PO, BID. Omeprazole 20 mg, PO once a day. Gabapentin 100 mg once a day. Prednisone 10 mg and given to be 7.5 ml BID and fluimucil 10 mg per sachet given 1 sachet 2 times a day. And for the other treatment done to this patient to correct the blood components, for the past few weeks, the patient received a series of PAC RBC from August 12 to September 10, and platelet concentration as well as fresh frozen plasma and plasmapheresis. Okay. For the main concern of this patient, disease progression and with signs and symptoms of active dying. Pain and symptom is progressively increasing. Noticeable sadness that leads to change of behavior such as loss of interest, irritability, and uncontrolled emotion. So to summarize all the aspect of this patient, despite the series of chemotherapy and other treatment done, it is significant that the disease is progressing due to recurrence of symptoms such as infection, fever, bleeding, difficulty of breathing, and pain. It is very significant that the patient has multiple hospitalization, patient begin to feel emotional distress, which leads to loss of interest and irritability. Patient referred to pediatric palliative care service for supportive management until end of life. Okay, for the discussion point for this session, so here are the question. How are we going to elicit the goal of care to this patient? What care to do the family needs during the dying process? What are the palliative care support that the family needs?
Thank you, Oyo, for the wonderful presentation. I hope that presentation is clear to everyone. So we can move on to the discussion parts. Mukta, over to you. So we would like to hear from you all. So we have a session. We had a session. Now we know. So what are the psychosocial issues and how important it is. We can discuss together.
Yeah, I also would like to know if anyone else is coming up with any ideas about these discussion points or anything else related to this boy. Anybody?
So just you can think about your own institution and you can think about your own ward, this kind of child. If you are take care of this kind of child in your that ward, so how will you manage? How will you elicit the psychosocial issues and all?
Currently, is the boy admitted or is he at his home?
Yeah, actually, ma'am, she expired a few days ago because of her condition.
Oh,
sorry. Oh. So she's no more. Anyway, we can discuss this type of patients in your ward. Maybe later also, if you can see this kind of patients.
right.
So yeah, you can do whatever you can. No, so we can discuss.
Actually, ma'am, we could and I have some sharing with the discussion points. So I'll show you the next slide. So for this patient, so in terms of discussion point, how are we going to elicit the goal of care to this patient? So under the service of pediatric palliative care, after the patient referred to us, we review the plan of care to assess the patient need in terms of pain and symptom management. We also conduct family meeting to also discuss with the patient and family the disease progression and what to anticipate through the course of the disease and provide support to the family, especially to the siblings of the patient. We also revisit the advanced care directive of this patient, and they agree that they were going to not resuscitate the patient and intubate. Then the next point is what care do the family needs during the dying process. So the pediatric palliative care service of the hospital assess the family understanding on the disease process. Then we do early discussion to family to help them anticipate changes in the patient condition since they have presenting the progression of the disease or what we call the dying symptoms. And also encourage the family to bond with their sick child. So we encourage the family to create meaningful memories like taking pictures with the family, playing favorite music and favorite videos of the patient. Then last point is what are the palliative care support that the patient and family needs. During this course, We provided the pain and symptom management, child life support, not only to the patient, but also to the siblings. We provide sibling counseling and psychosocial support to the family and to the patient, and also provide a spiritual support.
That's really comprehensive, the way that you've presented, and it's really nice, the discussion points. And I think you have covered almost everything that needed to be covered in the psychosocial care aspect of it. And definitely, I think here siblings is definitely a very, very major, they also have a major role to play, and they also need to be looked after and taken care of. And especially when you speak of emotional distress that the child was going through, so irritability, not doing things, not like losing interest in things, here we can definitely, if we could take sessions with the siblings and take the help of the siblings to actually help alleviate some emotional distress for the child, that is something that can be done in future cases, probably.
Yes, I agree.
Yeah, yeah. But yes, very, very nicely presented, and especially the way you explained about what all things were done for the family.
Thank you so much.
Yeah.
So anybody wants to add anything? So as Mukta said, you did a very good job. So sorry to hear that the child is no more. So now you can think about all of you can think about 9-year of old girl suffering with this kind of disease, and so that family also, you can think about the parents, you can think about always, you can think about the siblings. So you can if you can conduct the family meeting as they did for that patient. So that is very, very important. You have to make them understand well, especially siblings. They should know what was happening, their loved one. So, and what was the treatment going on, what is the prognosis of that patient, that child, that all should know. That siblings also, siblings and parents should know. So now we know how to break the bad news. So you can use the spike protocol when we communicating bad news to the caregivers or siblings also. The step by step you can do that, you can follow that steps. So here also there are a lot of psychosocial issues in this patient, but you did well. You have covered all the 4 aspects. Thank you so much for presenting this full story with us. So can we wind up the session, Mukta? So I think we all covered. Yeah. Thank you. Thank you, Mukta, for presenting a wonderful presentation today. And you have covered, as I mentioned earlier, you have shared your own experience also. So that would be very nice. I think that will help them a lot, because they can able to connect with that patient story. Whenever they have seen patients, they can also connect with these stories. And also you can present a wonderful patient story. Understand the patient is no more, but even we can discuss, we will discuss no. So if we have seen these type of patients, we later also we can do something for that patients. We will do something, some care. We always care for that patients and family also. Okay. So thank you once again for your attending, for